Hello and welcome to the Vestibular Disorder Association's video education event. Today's educational event is about balance training in the vestibular rehab clinic. Last month we talked about balance therapy at home, and this month we're going high tech. We're going to talk about how perturbation is putting the motor into sensory integration, evaluation, and training. Now, I thought we'd start with an exercise to get our motors running. Try to say perturbations 5 times fast, right? Rest assured, though, our guests will make this all clear by the end of this event. This VeDA live educational offering is brought to you by MediTouch, who is the developer and manufacturer of a new and novel balance system. This talk will be informative for both vestibular warriors and healthcare professionals. Understanding the balance system and the way it's treated can be quite helpful for those undergoing or considering vestibular physical therapy or vestibular rehab. Today, we're joined by Lou Nashner and Amy Downing, who will share the science behind this new device and the encouraging evidence and outcomes made possible by this balance platform.
Now, without further ado, let me take some time to introduce you to our amazing guests. They have long resumes that are very amazing. So bear with me here. I want to introduce both Lou and Amy. Lou Nashner received both his bachelor's and master's degrees in aeronautical and astronautical engineering from MIT. He then received his Doctor of Science degree in neuroscience and human balance and movement control, also from MIT. Lou's postdoctoral and continued research in his career have been primarily in the field of human balance and movement control. Then Lou's industrial career started in 1983 when he founded Neurocom International Incorporated. At Neurocom, Lou acted as chairman and CEO up until Neurocom's acquisition by Natus Biomedical. Headed by Lou, Neurocom pioneered and became the worldwide leader in computerized robotic devices for evaluation and rehabilitation of patients with chronic balance and mobility disorders. The company's product line grew to include devices assisting physicians in diagnostic assessment, treatment and planning, and outcome documentation, as well as devices used by physical therapists in the rehab process. Since the sale of Neurocom, Lou has served as a business and product development consultant for several companies, including Vertec, Intelligent Automation Incorporated. And in 2015, Lou turned his vast research knowledge to the continued development of perturbation-based balance training, and together with MediTouch, has been responsible for the continued development of this exciting modality. Welcome, Lou. And then also, let's turn to Amy. Amy Downing is a physical therapist, vestibular specialist, and clinic owner of Element Physical Therapy. She has more than 32 years of experience as a physical therapist and earned both her bachelor's and physical therapy degrees from St. Louis University. After graduating in 1990, Amy gained unique and specialized experience while working at the Rehab Institute of Chicago, Barnes Hospital in St. Louis, Missouri, and Sister Kenny Institute in Minneapolis. Amy has a keen interest in balance rehab, concussions, and working with patients with dizziness and vertigo. She herself has bilateral Meniere's disease, vestibular migraines, and a left perilymphatic fistula after performing a 25-foot free dive off the coast of Kona, Hawaii. Her clinic Element PT now houses state-of-the-art equipment, including Smart Equitest system by Natus and the Balance Tuner, clinic-based perturbation and gait treadmill. Amy is an Emory certified in vestibular rehabilitation and has obtained certifications in advanced vestibular rehab, cervicogenic dizziness. She also lectures in vestibular trends course at the University of Montana. And in addition, she also enjoys working with orthopedic patients as she played junior Olympic and collegiate volleyball. Oh, welcome to both of you guys. I'm really excited about today's talk. This technology is really awesome, and you guys have some cool stuff to show us. So, Lou, I'm going to pass it off to you. I want to have you tell us a little bit about this balance tutor system.
Well, thank you very much. First, I'd really like to begin by thanking VeDA and MediTouch USA for sponsoring this important event in looking at opportunities with perturbation treadmill training in terms of balance rehabilitation. And I'd like to start by reviewing some important fundamentals of balance movement control. Thank you for advancing that slide. I think we need to start by realizing that there are two fundamentally different types of balance movement responses. Reactive responses occur when the body, either in standing or walking, is unexpectedly displaced from its position and balance. And the reaction to recover balance is elicited by feedback signals. The other type of important balance responses are anticipatory responses, and they occur when a perturbation event is predictable. For example, I'm walking at the airport and I'm going to reach down and grab my heavy suitcase. That clearly is going to disrupt balance, and my body is going to adjust in advance so that when I pick up the suitcase, I can smoothly move on. So the important thing to realize at this point is when we talk about perturbation treadmill training, we're going to be focusing on reactive balance responses. So if I could have the next slide, please. So to review, reactive balance responses elicited by feedback signals when the body is displaced beyond the base of support. There are also reactive in-place responses that occur when the body is displaced, but it remains within its base of support. Now, for those of you who are familiar with computerized posturography, even the Natus Equitest system or Balance Master or the Vertex systems, to the extent that they look at balance movement responses, they're looking at in-place responses where the adjustment is made without having to step. The treadmill, the perturbation treadmill that we're talking about, takes this to the next step, as it were, and looks at what happens in terms of reactive movement when the center of gravity is displaced beyond its base of support. And if we could have the next slide, why is this really an important advance for balance rehabilitation? Well, if we think about daily life and when balance challenges and falls occur, most of the time they occur when we're walking or doing other weight transfer activities. For example, getting out of a chair, climbing in and out of the shower or a bathtub, in and out of a car, reaching for something in the kitchen. These are all weight transfer things where the center of gravity of the body is moved beyond the base of support. So if we can have the next slide, let's start by talking about, and I'm going to use some kind of simple illustrations and hopefully appeal to your intuitive sense as to how these work. Now, let's start by recalling in the left side, I show a picture of looking down at a person standing on a surface, weight equally placed between the 2 feet, and the center of gravity projection is that little green arrow, X, which is centered. So the person's in balance. Now, if they're perturbed a little bit in that space, then all is required is a pushback to the original position. So the response of the in-place balance reaction is resistance to whatever motion occurs. Now let's look at what happens if the center of gravity is perturbed outside the base of support, and that's the red arrow and the X. So suddenly pushing back is not going to work anymore. So how does the body correct? Well, it's now a 3-stage process rather than a simple resistive pushback, because what needs to happen is center of gravity is now forward, of the base of support, and the person's going to fall unless they can reestablish a new base of support. The first step is weight is shifted to 1 foot. Could be either side in this case. In my example, weight shifts to the left foot. And then the right leg, which is unweighted, the second phase is a step forward. And then the third phase is to weight the forward stepped right foot, now creating a new center, a base of support, which is a diagonal of the 2 striped feet in the right box. So the big difference, in place balance reactions are just simple resistive responses. Step balance reactions, even in the standing position, are 3-stage movement processes that involve first a weight shift, then a step, and then a reweighting. Important difference that we'll talk about a little bit more before I'm done. One thing you'll notice right away, and this impacts rehabilitation. Let's say I want to retrain this ability to do this step out following a forward perturbation. If the subject knows that they're going to get a forward perturbation, they can short circuit half of this process and stand and wait on one side, ready to take the step. So that already tells us if we want to work on this, we can't do this kind of activity by itself. And that would be true even if we're going to do a backward step. Forward-backward training by itself is not going to work very well because patient can always anticipate that something's going to occur and they get ready. And so they only have to make half of the process. The other half is done in anticipation. So we can have the next slide. Let's talk about one way to get around this. Let's look at lateral reactive step responses while the subject is standing in place. So now, instead of being perturbed forward or backward, the center of gravity in the left slide, at the left side box, is initially placed equally on the 2 feet, center of gravity projection centered in the base of support, and then suddenly something pushes the center of gravity off to the right outside the base of support. Now what has to happen? Well, the process is fundamentally similar, and that is weight shifts first to the left leg. Now this is absolutely opposite what would have to occur in a in-place reaction. Because remember, if you shift somebody a little bit to the right, but within the base of support, you just put the weight on the right foot. Well, in this case, that's not going to work. So instead, the weight actually has to shift opposite the movement to the left leg. Then the right leg picks up and is steps back down out to the right outside the original base of support, and then is reweighted, and now you've established a new base of support and balance. Now, think about this process. If I don't know which direction I'm going to be perturbed laterally, then unweighting in advance is a counterproductive strategy. The best thing I can do is stand, if I'm in place training, stand equally weighted and wait for things to happen and then react. And if we're going to mix lateral with the forward and backward, that will prevent the subject from anticipating the forward backward. So here we can already see by understanding how this process works, it tells us something important about training, and that is we better mix the directions of perturbations if we're going to look at step reactions. We don't have to do that if we're looking at the in place like is done on the Balance Master or the Vertex system, but we have to do it here if we're going to look at in place. So now, the next slide, let's look at probably the most important thing, and that is what happens when balance is perturbed while we're walking, which we haven't been able to do before with in-place types of technology, but on the perturbation treadmill, we can do this. So we can extend this process to walking, which really, in real life, is where we need to be with regard to reactive step training. So let's first look at the left box and imagine that the subject is in the single support phase of gait. So the right leg is swinging, the left leg is standing on the surface. The center of gravity is, during that phase, shifted over to the left. And now suddenly there's a perturbation which perturbs the center of gravity rightward. Well, in this case, it's a fairly simple reaction, and that is that the person re-guides the swing phase of the right leg to step out laterally so that the next step, instead of staying within the fairly narrow confines of forward gait, will step out to the right. That works pretty well. And in fact, this is probably, in some ways, an easier movement than the lateral step outs during in-place standing when it's unexpected. So now let's look at the more complicated situation. And this is probably the most difficult one. A reactive step responses. Now on the left side, the subject is in the left stance phase, the right leg is swinging, but now the unexpected displacement sends the center of gravity, the red X, to the left, laterally outside the base of support. Now, what has to happen? Well, the swing leg now needs to be placed left of the left leg to be able to recover balance. And this requires what is called a crossover step. Now, for anybody that's retrained or rehabilitated patients that have had, let's say, a stroke or anything that is impacting their coordination of the lower extremity is going to realize that this could be very difficult to achieve. You know, things like as the right leg crosses over, it hits the left foot, stumbles. There can be a lot of problems. So in review at this point, I think you can see that once we go from looking at simple in-place balance reactions to looking at balance movement reactions that require a step, life gets much more complicated. It depends on what we're doing. If we're walking, it depends on what phase of the step cycle we're in relative to what direction the perturbation occurs. And if we're standing, it's the same thing. It's going to vary depending on how our weight is at that moment and what the relative to the direction of the perturbation. So let me, with the next slide, kind of summarize why this is very important in terms of rehabilitation. The first thing we know from research studies that look at things like EMG responses is that these step reactions are organized at higher levels in the central nervous system compared to the simple in-place balance reactions. You recall from posturography and the Burtek and the Equitest, when you look at the motor reactions, the mechanical responses to a perturbation around 120 or 130 milliseconds, EMGs were around 100. Well, it turns out when you look at these step reactions that require a step out, the step reaction latencies at the EMG level are over 200 milliseconds, twice as long, and the mechanical sequelae are in the 250 to 300 millisecond range. So they take a lot longer to occur. That tells us they're organized at a higher level in the nervous system. The second thing is they're complex and they involve several phases, and the phasing depends on the situation. So again, something that's complicated and not just a simple pushback every time. So the other thing is that there is some research now, there needs to be a lot more, looking at what sensory systems control these step reactions. But the evidence to date suggests pretty clearly that visual and vestibular systems influence these step reactions. In fact, there's evidence to suggest that vestibular deficits may actually impair some of these step reactions, particularly asymmetries would impact the lateral step outs. So what does that mean in terms of rehabilitation? Well, what we know from rehabilitation in general, once you have a system with multisensory involvement involving higher levels of the nervous system, we know that there's greater opportunity for substitution and adaptive learning strategies. So that tells us, even without looking at what actually happens in rehabilitation, that we would expect that these step systems, the reactive steps, can be trained. Longer latencies allow more time for higher levels in the CNS to contribute to this learning process. So that's definitely a positive in terms of rehabilitation. Actually looking at rehabilitation of this system is very new, because the MediTouch Balance Tutor is probably the first system out there, and it hasn't been out there very long, that can perturb during walking, both in the forward-backward direction and lateral. And as I mentioned, it's important to be able to do both and to randomize. So I think without further ado, I'd like to pass the podium to Amy. And I think she's going to show you how some of these play out in the real world of rehabilitation. Thank you.
Thank you, Lou. I appreciate your presentation. It was very informative. Okay, so we can advance to the next slide. I am going to talk a little bit, just there's one slide on sensory integration and motor integration. Lou had already just gone over that. Several treatment diagnoses that we have seen in our clinic, as well as how to clinically treat using the balance tutor itself. Along with a case study, I'll do that at the same time. I'll show some videos, and then your return on investment in the clinic for having the balance tutor. So sensory motor integration, there's three things. I know you can read this. Sensory motor integration refers to the link between the nerves, the sensory system, the muscles, so motor skills, and to the process of receiving information through our senses, interpreting it and organizing it. And that's very important. This process relies on the synergy of the sensory system and muscles. And this typically happens in 3 stages. Just to keep it very simple, the first stage would be you have a sense organ such as your eyes or your inner ear, the vestibular system or proprioceptive system, and it picks up on a stimuli, okay, a stimulus, something that's going to cause a reaction. Then the nerves communicate to the brain, and the brain processes that information. The brain then uses the processed information to decide how to respond to the stimulus. It sends instructions to the right group of muscles to activate the appropriate response. So there's a lot going on in a very short amount of time. And I think that's important to understand how we integrate that sensory and motor systems themselves. Okay. This is just a partial list of diagnoses we treat in our clinic. We treat definitely post-concussion syndrome. We treat anything from kids all the way up through adults, with motor vehicle accidents being the #1 reason for most post-concussion syndrome. Mild TBI, any orthopedic impairment, truly you can treat the ankle, hip, knee. We have sensors you can put on the shoulder and things like that. So there's a lot we can do. Neurologic impairments, the sky's the limit. As long as they can stand and use their legs, we definitely put them on the balance tutor. Parkinson's disease, as Luke can attest, where there's quite a bit of information out there on how that the balance tutor stepping response and training that improves Parkinson's patients' ability to walk and keep upright longer. So to not kind of have them at a fall risk. So it improves that. Vestibular diagnoses such as hypofunctions. We can do vestibular ocular reflex training. We had a head injury that we did the cervical spinal reflex, excuse me. We treat balance disorders, CVAs, cerebellar ataxia. We have a patient who's gotten incredibly better with that using the balance tutor. CP anxiety regarding fear of falling, just one comment on that. We had a woman who came in for treatment and could not find any organic reason for her falling. She did have an extreme anxiety all around falling. We put her on the balance tutor and showed her that she can stand up and stay standing, starting with an anticipatory response and then move to a reactive response. So you can go to the next slide. Clinical tests, some of you may have this in your clinic, you may not. The Smart EquiTest system by Natus, Vertec has a version of that for the sensory organization test, motor control test. So other people use Cobalt, sit to stand, 5 times sit to stand, the Berg, the mini best test, the ABC, DHI, DGI, FGA. The ones that have asterisks next to it are the APTA core outcome measures. So there are various tests that you can use. This slide is showing you the balance tutor. There's someone actually behind the control panel, and he's just showing you how the whole treadmill, the base of that treadmill can move laterally. You can see the belt is running. We can also make the belt itself go faster, or we can slow it almost to a stop to cause the AP perturbations, the anterior posterior. So he's showing you here a little bit about how the balance tutor works, and he's getting himself into the harness. The harness is not meant to be weight bearing itself, so we don't want to put anyone who's dependent in that harness, but rather it's used, it's a very sturdy harness used to catch somebody if they were to fall. So he's just showing you how it's set up, and then how he stands in it. Seems ready to go. Okay, I'll take the next slide. Great. So here we're showing a patient that had a CVA. Okay, so we're doing the medial lateral perturbation in standing. And I want you to note on the left side of the screen how he is trying to maintain his balance once he had the perturbation. As Lou mentioned, he is showing the crossover step. Now, what's important to remember is that in standing, the leg that is more weighted is going to be the stance leg. So in this case, he's standing more on the right leg and he does a crossover with the left. So he's shifting of the body in the opposite direction to the perturbation. On the right, you'll see the same as well. He's crossing over, as you can see. The crossover step to the opposite direction of the perturbation direction. Now, this is very difficult to achieve. I have found without the balance tutor, just for safety in the clinic, that we would have to be able to hold him up if he were to fall. But here in the balance tutor, it's a nice place to be, that if he were to fall, he could actually just sit down and then we could bring him back to standing. You get increased sensory integration as mainly force and tension applied to the lower limb to the opposite direction. Okay, you get increased reversal activation of GM muscle, mainly type 2 muscle fiber of the lower limb in the opposite direction to the perturbation direction. You get an increased activation of the lateral canal of the vestibular system, which is important. And then activation of the inner spatiotemporal distal to proximal coordination pattern. So there is a lot going on here neurologically and also through the use of other systems. So I always say to my patients, repetition, repetition, repetition. As physical therapists, we like to quickly advance to the next exercise, but actually what these people need is basic repetition, and so the brain can learn from that. Okay, so next slide, please. Thank you. And then we're going to show the same medial lateral perturbation, however, during the gait cycle here. So as you can tell, the treadmill is not moving very fast. However, he has to figure out how to stay upright. So the execution of a compensatory step, good job, by the swing leg to the opposite side of the perturbation direction. So as the treadmill moves to, in this case, to his right, he takes a step to his left. You need dynamic stabilization of the lower limb joint in single stance phase, okay? And increased sensory integration ability. So this is a more complex task. And as you can see, he's doing the stepping response beautifully. However, he appears to be struggling just a little bit. But again, this is how he's learning. So it's a great way to, again, repetition, to teach him how to do this. Okay, next slide, please. I just want to show you the anterior posterior perturbation in static standing. So the treadmill is not moving until we give him the perturbation, which is obviously the movement. Balance strategy practicing. So here we go with the ankle, hip, and compensatory step in the sagittal plane. Okay, there he goes, stepping backwards. The step initiation practicing, mostly the less loaded limb initiates the stepping. So I said that previously, that when you put more weight on one of the legs, the opposite leg, the weight that is more unweighted, will take the step. You're getting increased vestibular system activation, mainly in the posterior canal. So it's causing him to take that step. And we're going to show the same thing here, the anterior posterior perturbation during gait cycle. So a compensatory step execution by the swing leg in the in the opposite side to the perturbation direction. Okay, so you can see how the treadmill's moving. He needs to take a step, but then we can add a perturbation to cause him to make a reaction, to cause a reactive step. You get increased sensory integration ability again, and that inner spatial temporal coordination pattern of muscles of the trunk and lower limb are demonstrated here. Medial lateral perturbation in standing. We take the same gentleman. Okay, so we're encouraging the body weight transfer. We're showing improvement of a crossover step with greater sensory integration. So the nice part about perturbations in standing is that as therapists, we can actually control the treadmill of when that perturbation occurs. We can also set certain parameters that it goes at a certain time as a timed response, but we can see when he is standing with there he goes, when he's standing center. In this case, we don't know, or we actually do know because there's a nice screen that shows us how much weight bearing he has on the right leg versus the left leg. So we can, as therapists, predict what he should be doing and then go ahead and continue with repetition of that so that he learns. If he were to fall or not know what to do, that's where we can come in with instruction and make it a little bit easier. So there is a threshold that you have to achieve. So we have to give enough perturbation that is going to cause a step. And that's a nice crossover step. And he's trying to come back and regain his center of gravity there over his base of support. Good. Okay, next slide, please. All right, and here's the same medial lateral perturbation during gait. This is him a little bit further down the road, meaning that he's already had some training. You can see the execution again of a compensatory step. You can also see how he's looking at his feet because he's not quite sure. He's using his vision to try to help him out there. So we're achieving stabilization of the stance leg. Okay, so in this case, it's his affected leg. Okay, and we're getting greater sensory integration as we continue to repeat this. So this is more mimicking if he were to go for a walk outside on, let's say, a sidewalk, and you hit a little bit of an uneven sidewalk, he would be able to, at this point, catch himself if he were paying attention. So that's what our aim is, our goal is. Even if he weren't paying attention, he would be able to get that reactive response. So next slide, please. All right, so physical therapists are always wondering about return on investment, or business owners. So sorry about that error in that code. That should be 97112 for neuromuscular reeducation. I think we're, as therapists, very familiar with that code, but we do use 97112. You can use 97116 for gait training if you are providing verbal cues on how, maybe perhaps you want to increase the step length or something of that nature. 96000 is a good question mark. The reason why is because I've heard some therapists that want to use this code. However, if you do use this code, you do need to videotape the computerized base gait analysis. There is a part on this machine, the Balance Tutor, where we can do a computerized gait analysis, and it does come with a printout. However, if you're going to use this code, you also need to include a video clip. We do not use this code in our clinic. We use, I'll have you advance to the next slide. We do use this code, 97750. which is a procedure code to bill for functional capacity exams, including physical performance tests and measurements, and including the writing of reports. So you can use this code to bill if you include the, if they ask for, if they're going to ask for documentation, make sure you include the gait analysis that has been printed and scanned into the chart to document the use for this code. So Medicare will pay for this along with the initial evaluation code, which is really nice, on the same day if you use the 59 modifier, and that still holds true. So, all right, next slide. I just thank you so much for allowing me to talk. We were wondering if you had any questions or anything you...
We actually have a great question to start off with. So we have someone in the chat asking that, is the idea of the lack of predictability while standing and walking better for our brain to compensate? Is that pretty much the idea of the balance tutor? Yes?
Wait. Go ahead, Lou.
Okay, I would say yes, that lack of predictability, I think, as you saw in my part of the presentation, is important in terms of forcing the nervous system to go through the entire planning process for making the movement. And of course, so I think that's probably the main point. And if you noticed in Amy's slides with the gentleman with the stroke, that when you were doing the lateral perturbation standing, stroke patients tend to weight one side, of course, usually the less infected side. And so what you noticed is that in one direction, he did a crossover, and in the other, it was a little different because the weighting was different. At least I think I picked up on that in some of them. So in real life, if we're going to do retraining of a patient like that, you probably want to move the patient toward more equal weight bearing to the extent that the impairment allows, because that's going to make the corrections more symmetric. So, yeah. So I guess what it comes down to is lack of predictability is important, and it's important relative to other things that the patient's doing that are creating asymmetry, like stroke, or a vestibular deficit can create asymmetry as well, and that's going to impact how the person reacts one way versus another.
We had another question too that kind of piggybacks on that vestibular input. And somebody asked, do perturbations stimulate the otolith primarily?
Yeah, I mean, in the case of the treadmill, we're talking about this, the surface is perturbed. So the position of the feet is perturbed relative to the center of gravity that initially stays where it is, which is to some extent, well, that can happen in the real world, but also in the real world, the other thing can happen is the upper body is perturbed and the surface is stationary. So depending on which occurs, it may be the otolith or not, but yes, I think the short answer is the otoliths are definitely involved.
I like the idea of the balance tutor because, as physical therapists, we're constantly trying to come up with ways to challenge our patients and kind of put them in these near fall situations to try to activate that fall response and train it, as Amy said, with repetition. But it's really hard to recreate those unpredictable motions and movements, especially in the directions that the balance tutor creates, which is amazing to see. It truly is amazing technology. And really cool to watch a real patient navigate on it and see how it helps.
It was. I was thinking about, for some of our viewers who may be less familiar with the real neuroscience behind this, I think what they're getting from it based on the comments is that balance is not just about standing still really well. You know, balance is not just, can I hold my balance in one place? But balance retraining has to include what we call in the field dynamic balance, which is these reactions that initiate a step response. And they're very, very complicated. So balance is more than standing still with your eyes open and eyes closed. It's more than taking a step or being able to respond or dance or whatever, because you have to have that surprise situation, because we're so good at anticipating things that we can immediately change our stance without even being aware of it after just one perturbation. So they have to be surprised. They have to be in different directions. And I think in the clinic, we ask patients to go out into the world and practice things for this reason, because we want them to have unpredictable things happen to them at the surface or in their upper body. But the Balance Tutor is a beautiful scientific model that not only is going to, or technology that's not only going to help patients who can access it, but really going to contribute to furthering the research. And I see that as a very big plus. The tech involved here is allowing us to put electrodes on those muscles or put electrodes on the brain and measure these reflexes that Dr. Nashner was talking about, to see what are just spinal reflexes, what happens quickly because the muscle is stretched, or what goes to the brain and includes the vestibular system, the visual system, and the integration of that. So these kinds of technology give the science, wouldn't you say, a beautiful tool to measure these reactions and help us learn as a field?
Yeah, I would say that, I mean, it's interesting. The perturbation treadmill research has been around for more than 10 years. In fact, if you look at the literature at the research level, including not only looking at basic science, but even research into rehabilitation approaches, has been around a long time. But for 99.9% of the rehab community, don't have the luxury and the money and the time and the engineering to make these devices themselves. And so the actual practical rehabilitation has not occurred till very recently, because there was not a commercial device that is actually realistic for clinical use available. And so now that has come on board. And so hopefully we'll begin to see that this will begin to proliferate within the rehab community. It was the same thing with balance. Mm-hmm. Balance research, those of us were doing it, I hate to admit how many years ago, a lot more than 50 years ago, but yet it wasn't a major part of rehabilitation, at least at the technical level, until manufacturers made practical devices, and then of course validated them, which is an important part of it, so that a clinician could use it without being an engineer.
Yeah, right.
Now, we've been using the word perturbation a lot in this talk. Maybe we should just define what that perturbation is. And can you guys give a couple of examples of what a real life perturbation might be that someone could experience?
Sure. So a perturbation is going to be a force that puts you outside of your base support, forcing you to take a step to stay upright. It's a, Lou, you might want to describe that, but it's just
well, some simple examples.
Yeah, I can do that.
And I'm in Chicago, and it's wintertime, and I don't notice it, and I come to a spot on the sidewalk that's icy, and so I put my right foot down, ready for the next step, and it slides out to the side. Now, that is a surface type of perturbation. Another one would be, I'm walking along and I'm not paying attention, and I take the next step, and I step on something that's either unstable, and the surface gives way, or maybe I step off the curb.
Mm-hmm.
Another one, I'm walking and there's a big crack in the sidewalk, and my toe stubs during the swing, stubs the crack in the sidewalk.
Mm-hmm.
Another one would be, and you can even do this kind of thing. Ask somebody to pick up an object and make it look like it's extremely heavy, and then it turns out to not weigh anything, and their arms fly up, and they may even stumble a little bit. So that's a case, that's an anticipated reaction that was inappropriate. Another type of perturbation. So life's full of them.
Yeah, and one other one is when you're at the airport and someone's excited to see you, so they come running at you to give you a hug. And the last thing you're thinking, oh my gosh, it will push me backwards. So, that's
just somebody's rushing by and bangs into you going by,
Not to mention moving on the moving sidewalk in the airport, or getting, so certainly, so that's just a fancy word for things that happen in the environment that are unpredictable. These are the things that catch people they catch people unaware, that are likely to produce falls. And the goal is to keep people feeling confident so they can move, so they can engage in their environment and live a life that's full and be safe. And I think we have another comment. Are the perturbations random, or can you program the perturbations on the MediTouch Bounds Tudor?
Well, the answer is yes. You can program them to be random. You can program them to occur, let's say, only if the patient's walking. Program them to occur only on left support, or you can randomize that. So like any computerized device, the ability to program exactly what you want in terms of when and in what direction is pretty broad.
It sounds like there's a lot of different features, that we've kind of mentioned, but you were saying that it measures weight bearing and which leg it's weight bearing. So you probably have some pressurized system in there too, that's looking at where you shift weight and how you shift weight. Will it read gait as well as they're walking on the treadmill and looking at what their gait pattern is like?
Yeah, actually, probably we should mention there is a force plate under the belt. So one has a measure of the center of force at all times. And so you can tell if they're, let's say, walking on the belt, which side, which leg is weighted at any given time. And in fact, that's used as the trigger. Let's say if I want to only perturb on left stance, the force plate will tell me when the patient's in left stance, because the center of force is off slightly to the left, and then I can initiate the perturbation. And then the other thing is, with the force plate, you can measure the reaction time to respond to the perturbation, including the weight shift one direction followed by the step out in the opposite. You can actually separate those events. So at the moment, I'm working with some other researchers and MediTouch to come up with a way of actually scoring the quality of a patient's step-out reaction in terms of how quick they are, and also mechanically how efficient they are.
And we can also do things such as dual tasking. So as they're walking or standing, we toss them a ball where we bounce it on the floor first, and then they have to catch it. And the balanced Tudor system comes with, you can get a sensor that can connect to a TV that when you turn around the patient, we can put the sensor on the forehead, you can put it on the shoulder, hip, knee, ankle, you can put it anywhere. But when you put it on the forehead, we can actually train the VOR because there's sensors playing a game where maybe you have to get a ball through a certain spot. So we can do that, give random perturbations. We can have them walking. So you can make it as complex as you can think up. So there's a lot of things to do, a lot of ways to train.
Well, we're getting close to the hour, and I think we can wrap up here. And it's been a wonderful, wonderful conversation. We are grateful to MediTouch USA for sponsoring this presentation and showing us the exciting new products available for enhanced vestibular and balance rehab. If you'd like more information about this product, you can go to MediTouch, and you can visit them at meditouchusa.com or email info@meditouchusa.com. Dr. Nashner and Amy, we are so happy that you shared with our audience this exciting futuristic system, how far we've come in the relative short history of vestibular and balance rehab. Dr. Nashner, I know I speak for all of us when I say thank you for your lifetime of commitment to exploring and validating and developing tools that are used in vestibular clinics and research labs throughout the world. And we thank MediTouch USA for their commitment to helping you find your way back to balance.